So when you hear terms like addiction or substance abuse, what comes to mind for you first? Do you maybe picture a moral failing or, a lack of willpower, something like that? Often our first thoughts, they're kind of shaped by older ideas, maybe outdated ones. Today, we're going to dive deep. We're going to challenge some of those common misconceptions. Welcome to the deep dive. We are really plunging into a critical topic and one that's often profoundly misunderstood: substance-related and addictive disorders, right? We've basically distilled insights from a really comprehensive source to help us unpack the true complexities of these conditions.
Yeah, and our mission today is really to cut through some of the noise. We want to clarify the terminology, explore the kind of surprising science behind addiction. We'll get into how widespread it is, its impact, and we'll touch on the different paths to recovery. The goal is really for you to get the knowledge quickly, but thoroughly, hopefully providing some aha moments without totally overwhelming you with information.
Okay, yeah, let's unpack this then. So one of the first things I think is understanding how the medical and psychological fields talk about this stuff. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, everyone calls it the DSM-5, it's actually moved away from terms like substance abuse.
That's right.
The term they prefer now is substance use disorder, or SUD. And this shift in language, it's really important, isn't it? Because it aims to reduce that significant stigma that's been attached for so long.
Absolutely crucial. But we know that word abuse still kind of hangs around in the public consciousness.
It does.
And when we talk about substance use disorder, or SUD, the DSM-5 defines it as, let me get this right, a cluster of cognitive, behavioral, and physiological symptoms indicating that the individual continues using the substance despite significant substance-related problems.
That seems pretty comprehensive.
It is. And what's interesting is how broad that is.
Yeah.
It applies to everything from alcohol and cannabis to hallucinogens, stimulants, the works. The DSM-5 also groups related conditions under this larger umbrella: substance-related and addictive disorders. So that includes the SUDs, but also substance-induced disorders. Things like acute intoxication, withdrawal symptoms, or other mental health issues directly caused by using the substance.
Right. So it's not just semantics, this language shift. It really highlights, a profound change in how we understand addiction itself. It's now characterized as a chronic relapsing brain disease. That framing seems critical.
It is. It moves it away from being seen as just a moral failing towards a medical condition, which is vital for reducing stigma.
And it's not just about chemicals, right? The DSM-5 also recognizes things like gambling disorder.
Exactly. Non-substance-related addictive disorders like gambling disorder are in there because, interestingly, they activate very similar brain reward systems. It really just shows how deep these conditions go, right into our neurobiology.
So, okay, how widespread is this challenge then? The statistics on substance use in the U.S., they really put it into perspective. Illicit drugs get a lot of headlines, but alcohol is actually the most widely misused substance.
That's right.
Then after alcohol, you see things like marijuana, cocaine, prescription opioids. Those are some of the most commonly used illicitly.
And the sheer scale, the numbers are pretty staggering when you look at them. Millions of Americans have battled alcohol use disorder, just millions. In recent years, we've also seen millions struggling with marijuana use disorder. Heroin addiction, that's seen a really concerning rise. It actually doubled over the past decade or so for hundreds of thousands of people.
Doubled? Wow.
Yeah. And we can't forget the opioid crisis, right? Millions affected by opioid pain reliever use disorder. And often that starts with a prescription. These numbers, they really paint a picture of a major public health challenge. It's not some niche issue.
It really isn't. And it hits different groups differently too, doesn't it? The prevalence varies across age and gender. For adolescents like 12 to 17, it's roughly 1 in 20. That's over 1 million teens with the SUD.
1 million teens?
Yeah, and then it jumps quite a bit for young adults, 18 to 25. There, it was about 1 in 6 battling a SUD back in 2014. And maybe surprisingly, for older adults over 65, up to 15% suffer from substance misuse. And over 3% of that group struggle specifically with alcohol use disorder. And looking at gender, historically, men struggled with AUD at double the rates of women back in 2013.
Which leads to a big question, right? If it's so widespread, why aren't more people getting help? Part of it is definitely a lack of enough treatment facilities. That's a huge issue. But a key thing here is that many people who actually meet the criteria for an SUD, they don't see themselves as needing treatment.
That's fascinating, like a gap in perception.
Exactly. For instance, a huge majority of adolescents who needed specialized treatment, well, they didn't get it back in 2015. That perception gap is a massive barrier to recovery.
And the cost of these disorders, it's not just personal, is it? It ripples out everywhere. We're talking huge involvement with the justice system. Get this, about half of American prisoners and people in jails suffer from addiction.
Half.
Yeah.
That's enormous.
It is. And beyond that, folks with SUDs often face more chronic health conditions, generally poorer health outcomes. It puts a massive strain on healthcare.
I mean, if we connect this back, there's this very high rate of other mental disorders happening at the same time as SUDs. People often call it dual diagnosis. What's really compelling, or maybe concerning, is that patients with a mental disorder have something like a 50 to 60% chance of also having an alcohol use disorder.
Wow, that high.
Yeah. One common idea is the self-medication hypothesis. Maybe using substances to try and cope with symptoms of another condition. But it's also clear there are overlapping genetic risks and environmental triggers, like acute trauma. Those can contribute to both mental health issues and SUDs. It's complex.
That comorbidity, it creates a really tough challenge. Like with marijuana use, right? Sure, there's the immediate high, but longer-term use is linked to this thing called amotivational syndrome.
Right. That loss of drive.
Yeah, apathy, loss of drive, trouble with learning, memory. And it's also tied to cognitive impairment and a higher risk for psychotic disorders, especially in people who are already susceptible. What's really sobering, too, is the suicide risk. It's significantly higher for people who misuse alcohol or drugs, like 10% higher than the general population, and even higher, maybe 15% for those with alcohol addiction specifically.
It's a devastating connection.
And physically, well, depending on the drug, how it's taken, basically all body systems can be affected. It leads to a whole range of health problems. Okay, now this is where it gets really interesting for me, and maybe where some folks have that aha moment. The neurobiology. How addiction actually affects the brain. It's not just about willpower, it's deeply wired into our brains. There are 3 core areas involved. First, the brainstem. That handles basic survival stuff, right? Heart rate, breathing. Keeps us alive.
The fundamentals.
Then there's the limbic system. People often call this the reward circuit.
Yeah.
It links pleasure with motivation, makes us repeat things we need for survival, like eating or bonding. And psychoactive drugs. They basically hijack this system.
I really do. And the third part is the cerebral cortex. That's for higher functions, problem solving, decision making, impulse control. And these are the very functions that get compromised in addiction.
Hijacked and compromised. That's quite a combination.
It is. And a key insight here is how these psychoactive drugs, they either directly or indirectly, just flood the brain's reward system with dopamine. Dopamine is huge for pleasure, motivation. It creates that intense high.
Right.
But, and this is crucial, with continued use, the brain adapts. It actually reduces its own natural dopamine production, or it cuts down the number of dopamine receptors. And this leads to tolerance, which means you need more and more of the drug just to feel, well, normal, let alone get the high you're seeking.
So the brain is literally rewiring itself.
Essentially, yes. It starts prioritizing the substance. It makes the choice to quit incredibly difficult, far more than just deciding to stop. It's a biological change. There are also alterations in things like glutamate concentration involved.
Wow. Okay, so beyond the brain's direct reaction, what other risk factors are involved in developing an SUD? Genetics plays a role, right? I've heard numbers like 40 to 60% of vulnerability might be genetic.
That's the current belief, yeah.
Yeah.
Genetics are a significant piece of the puzzle, but not the whole story. You also have a whole range of psychosocial and cultural risk factors. Things like adverse childhood experiences.
Proxides, like trauma.
Exactly. Physical or sexual abuse, witnessing violence at home, parental substance misuse, parents separating or being incarcerated. These early experiences can have a huge impact. Also things like lack of economic opportunity, poor self-image, peer pressure. It all contributes.
And culture, how does that fit in?
Well, there are some fascinating examples like in some East Asian populations, there's a common genetic difference in an enzyme that breaks down alcohol, acetaldehyde dehydrogenase. This causes unpleasant reactions like flushing, palpitations when they drink alcohol. And that biological difference can impact the rates of alcohol use disorder in those groups.
That's really interesting how biology and culture interact there.
It is. And it's intriguing how, while specific drugs have unique effects, there are common things we see across different substance use disorders, like blackouts, for instance, periods of amnesia while drinking. Intoxication, that's the state right after taking the substance. Overdose, which is obviously a toxic, dangerous level.
Right.
Then withdrawal, those really difficult physical and psychological symptoms when someone stops using after becoming dependent. We mentioned tolerance.
Needing more for the same effect.
Exactly. And there's cross-tolerance, too, where being tolerant to one drug, say alcohol, makes you tolerant to another, maybe like a benzodiazepine. They're in the same class. You also see synergistic effects, where taking two drugs together makes the effect much stronger than either one alone. Think alcohol and sedatives.
Dangerous combination.
Very. And the opposite is antagonistic effects, where one drug blocks another, like naloxone blocking opioids. Some people also experience flashbacks, sudden recurrences of perceptual stuff from, say, past hallucinogen use.
And you mentioned codependency earlier. How does that fit?
Right, codependency. It's really important in the context of recovery. It describes this kind of dysfunctional helping relationship, where one person, maybe unintentionally, enables another's compulsive behavior, often sacrificing their own needs. It shows how addiction really affects the whole family, the whole support system.
That makes sense. Okay, let's maybe talk about some specific substances, starting with alcohol, since we said it's the most widely misused. For an alcohol use disorder diagnosis, or AUD, someone generally needs to show at least 2 out of 11 specific symptoms over a year. Things like craving, tolerance, withdrawal.
Correct.
And just for context, what's considered heavy drinking? Is there a standard definition?
There are general guidelines, yeah. For men, it's typically defined as more than 4 standard drinks on any day, or more than 14 per week. For women, it's a bit lower. More than 3 standard drinks on any day, or more than 7 per week. These are just guidelines, of course, but they give a sense of risky levels.
Okay. And when someone with AUD stops drinking, they can experience alcohol withdrawal syndrome, AWS. This isn't just a bad hangover, is it?
No, not at all. It can be very serious, even life-threatening, has distinct stages and symptoms. You can see autonomic issues. The body's automatic systems go haywire. So elevated blood pressure, fast pulse, higher temperatures, sweating heavily. Then motor symptoms. Things like bad tremors, the shakes, overactive reflexes, and in severe cases, seizures. Their awareness can be affected too.
Yeah.
Agitation, confusion, disorientation, leading potentially to delirium.
Delirium, like the DTs.
Exactly. Delirium tremens, or DTs. That is a full-blown medical emergency. It needs immediate treatment. And there are psychiatric symptoms too.
Yeah.
Intense anxiety, seeing or hearing things that aren't there, hallucinations, paranoia.
That sounds terrifying. And doesn't necessarily end there, right? There's something called PAWS.
Right. Post-acute withdrawal syndrome, or PAWS. Even after the acute phase passes, many people experience these lingering symptoms. Things like persistent mood swings, anxiety, irritability, energy levels that go up and down, low enthusiasm, trouble sleeping. And the tricky thing is these PAWS symptoms can kind of come and go, wax and wane, for potentially up to 2 years. It makes long-term recovery really challenging.
2 years. Wow. Okay, let's shift to opioids. We're talking about things like heroin, oxycodone, morphine, and fentanyl.
Yes, and fentanyl is incredibly potent. Something like 50 to 100 times stronger than morphine. It's driving a lot of the overdose deaths currently.
And you mentioned a powerful link earlier that most current heroin users started with prescription opioids.
That's a key statistic, yeah. Approximately 80% of people who currently use heroin reported misusing prescription opioids first. It highlights that pathway, an often unrecognized connection.
That's huge. And opioid overdose, what are the signs? How can it be reversed?
The classic signs of opioid overdoses are often called the triad. Pinpoint pupils, severely slowed or stopped breathing, respiratory depression, and decreased consciousness, or passing out.
Yeah.
The vital thing to know is there's an immediate reversal agent, naloxone. You probably know it as Narcan. It can rapidly counteract the overdose effects if given in time. It saves lives.
Narcan, right. Okay. What about central nervous system stimulants, like cocaine and methamphetamine? They work differently, pushing things into overdrive.
Exactly. They stimulate the central nervous system. Cocaine gives this really quick, intense, but very short-lived high. It works by messing with dopamine and norepinephrine, so you get increased alertness, excitement, loss of appetite, but also paranoia. And the crash afterwards can lead to severe, even suicidal depression.
And methamphetamine, is it similar?
Similar in being a stimulant, but methamphetamine is different. It's not only highly addictive, it's actually neurotoxic. It poisons and damages brain cells. Specifically, it can destroy dopamine and serotonin cells. This can lead to really long-term problems like visual hallucinations, deep delusions, and persistent paranoia, even after stopping use.
That sounds incredibly damaging.
It is. And then there's nicotine, which, it's legal, widely available. It holds this grim title. The greatest single cause of preventable illness and premature death.
More than anything else.
More than anything else preventable. It's directly linked to chronic lung disease, COPD, emphysema, stroke, many types of cancer. The list is long. And even with e-cigarettes becoming popular, we need to remember they aren't harmless. They can contain nicotine, obviously, but also a lot of other toxic chemicals. We're still learning the long-term effects.
Right, the vapor isn't just water. Okay, let's circle back quickly to marijuana. We mentioned amotivational syndrome and cognitive issues. Anything else?
Yeah, something we're seeing more, especially with higher potency cannabis products, is cannabinoid hyperemesis syndrome, or CHS. It's this really severe condition characterized by recurrent, intense vomiting and bad abdominal pain. It can be incredibly debilitating for people who experience it.
Vomiting from cannabis, that seems counterintuitive.
It does, because we often associate cannabis with anti-nausea effects, but in some chronic, high-dose users, it seems to have this paradoxical opposite effect.
Okay, this brings up another really important question. What about using these substances during pregnancy? What are the risks?
The risks are significant, and they vary by substance. Alcohol is what we call a teratogen. It's directly toxic to fetal development. Drinking during pregnancy can cause fetal alcohol syndrome, FAS, or the broader fetal alcohol spectrum disorders, FASDs. These involve serious birth defects, cognitive disabilities, developmental problems, lifelong challenges.
Lifelong?
Yes, nicotine exposure during pregnancy is linked to things like low birth weight, developmental disabilities, and importantly, a higher risk of sudden infant death syndrome, or SIs. And for opioids, using them during pregnancy can lead to premature delivery, low birth weight, and something called neonatal abstinence syndrome, or NAS, in the baby.
NAS, what's that?
Neonatal abstinence syndrome. The baby is essentially born dependent on the opioid and goes through withdrawal after birth. Symptoms include things like significant irritability of the central nervous system, tremors, feeding problems, gastrointestinal issues. It requires specialized care and can have long-term developmental consequences.
That's heartbreaking. Okay, so knowing all these challenges, the brain changes, the risks, what helps? What are the pathways to healing? Let's talk treatment. A key concept seems to be medication-assisted treatment, or MAT.
Yes, MAT is really considered the gold standard for many SEDs, especially opioid use disorder and alcohol use disorder. And it's important to stress, it's not just about the medication. It's a comprehensive approach. It combines FDA-approved medications with counseling and behavioral therapies, treating the whole person.
Right, the assisted part is key. So what medications are used for alcohol use disorder?
Yeah, there's several helpful ones. One is disulfiram, brand name and abuse. It works through aversion therapy. If you drink alcohol while taking it, you get really sick, nausea, vomiting, flushing. It's a strong deterrent. Then there's naltrexone, brand names Rivia or Vivitrol, which is an injectable form. Naltrexone actually blocks the euphoric effects, the good feelings, from alcohol. It also helps reduce cravings. And interestingly, it's used for opioid use disorder too. Acamprosate, or Camprol, works a bit differently. It helps reduce the unpleasant symptoms of prolonged abstinence, like anxiety, restlessness, insomnia. It helps normalize brain chemistry.
So different mechanisms.
Exactly. And another one showing promise is gabapentin. It's used off-label sometimes, but studies suggest it can help with alcohol dependence, preventing relapse, and even managing co-occurring SEDs or anxiety. These meds essentially help the brain heal and function without alcohol.
That's good to know there are options. What about for opioid use disorder? You mentioned naltrexone works there too.
Yes, naltrexone can be used for OUD, often after detoxification. But the mainstays of MAT for OUD are typically opioid agonists or partial agonists. Methadone is one. It's a long-acting, full opioid agonist. It prevents withdrawal symptoms and reduces cravings. It's typically dispensed in structured clinic settings. Then there's buprenorphine, often combined with naloxone in products like Suboxone. Buprenorphine is a partial opioid agonist. This means it binds to the opioid receptors, enough to prevent withdrawal and reduce cravings, but it has a ceiling effect, meaning it doesn't produce the same intense high as full agonists like heroin or methadone, making it safer in some ways. It allows people to stabilize their lives and engage in recovery.
So it satisfies the receptor without the big high.
Precisely. There's also nalmefene Revex, which is similar to naloxone and primarily used for reversing opioid overdose, though less common now than Narcan. And relatively recently, in 2018, Lucemyra was approved. It's actually a non-opioid treatment specifically designed to help lessen the severity of withdrawal symptoms.
Good to have non-opioid options too.
Definitely. And we shouldn't forget nicotine cessation. There are pharmacological aids there too. Things like nicotine replacement therapy patches, gum, lozenges, sprays, and prescription medications like Varenicline, Chantix, or bupropion, Zyven. They all help manage cravings and withdrawal, making quitting tobacco easier.
Lots of tools in the toolbox then. Before we wrap up, you mentioned something else. Spirituality. How does that fit into recovery for some people?
Yeah, it's an important component for many individuals in recovery. And it doesn't necessarily mean organized religion, though it can. It's often broader. A sense of connection to oneself, to others, to nature, or to a higher power, however someone defines that. It involves finding meaning, purpose, cultivating things like hope, gratitude, compassion. For many, connecting with this spiritual dimension provides immense strength and resilience during the healing process. Mind, body, spirit connection.
That's a really holistic view. Okay, so we've covered a lot. What does this all mean for you listening? We've talked about this huge shift in understanding addiction, moving away from seeing it as a moral failing
Yeah.
and really recognizing it as a chronic, relapsing brain disease. That seems fundamental.
Absolutely fundamental.
We've looked at how incredibly widespread these disorders are, how often they overlap with other mental health conditions, that dual diagnosis piece. And we dove into the brain science, how substances can essentially hijack the brain's reward system, and touched on the complexity of symptoms, withdrawal, and the different treatment approaches that offer real hope.
And if we bring it all together,
Mm.
really understanding these facts, the science, the prevalence, it's our best weapon against the stigma that still surrounds these conditions. Knowledge really is power here. It helps us challenge those old misconceptions, that discrimination, and allows us to see the person who is struggling, not just the disorder.
Well said. So here's a final thought to leave you with. Given how much our scientific understanding of addiction has evolved, how much it's changed, what societal shifts might we still need? How can we better support individuals who are struggling with these really complex brain disorders and finally move beyond those outdated, harmful misconceptions? Just something to consider. The power that accurate information has to foster compassion and ultimately to build more effective solutions for everyone affected.